Okay, so I don't have much to say about fluids. We'll talk about them very briefly. Have you guys had fluids or talked about electrolyte balance and that type of stuff in another class? Okay, well, start here. There's maintenance fluids that we give patients. When we say push a liter of fluids or give fluid replacements, these are the things we're talking about. The vast majority of replacement fluids that you're going to give an adult patient are going to be normal saline. It's isotonic, and 0.9% is what's considered normal saline. So if somebody's septic and they come in and their blood pressure is tanking, first thing we do is push fluids, usually 20 to 30 milliliters per kilogram, and that's always in normal saline. You can't really do any damage with normal saline. It is sodium content, but it's and I'll talk about this later when we talk about the sodium imbalance stuff, but it's more or less impossible to get somebody overboard on sodium with normal saline just because the body will equilibrate it properly, unless they have like really, really bad kidney function or something. But even then, it's pretty hard to do that. Everything else, it's all a matter of looking at tonicity. So like there's half normal saline, there's D5, there's combinations. So like by itself, half normal saline isn't quite isotonic, but if you want it to be, you can do D5 plus half normal saline. That's another really common fluid people run. Most of the time we don't use D5 as a replacement or maintenance fluid for fluid replacement just because it's a lot of sugar over time. So there's a number of conditions where that's problematic. And a lot of times in hospitalized patients or emergent patients, you don't want fluid and insulin, and that whole balance system that we haven't talked about yet is not something we want to mess with or get out of whack. And it's really common for people in the critical cares to require a little bit more aggressive insulin management or blood glucose management. So to give some fluids on top of that, oftentimes we find ourselves trying to restrict dextrose-containing fluids. But a lot of drugs that are infused IV have been studied in dextrose and are more compatible in it. So a lot of times the drips we hang, or if you're getting like 100 ml antibiotic in a bag one time, a lot of those are in D5. So that's something that you'll see quite frequently, but it's not a common replacement solution. So it's more of like a diluent or something we put drugs in because it's more stable. But a lot of those drugs work in normal saline too. It's just some of them don't have evidence to match that. So you end up seeing that. But if you're ever concerned about your patient, and so this is really the only take-home point of this whole slide. If you're concerned about your patient and you want, you're like, oh, they're getting so much dextrose, and you're looking at all their meds, and maybe you're doing critical care in the ICU, or even hospitalized patients on like a med surge floor would apply to this sometimes. But you might have somebody and you're going through all their meds and all their lifts, and they're on a bunch of IV stuff, and it's all in dextrose, and their sugars are creeping up. You could contact pharmacy and see if they could switch some stuff to normal saline. Something happens quite frequently. But just know there are other options for that. And that's the main difference between the two. Dextrose usually is what drugs are going to come in. Normal saline is usually going to be the maintenance fluid you're going to see. But 2 years ago, we had a big shortage of fluids because the biggest company that makes fluids, Baxter, their facilities in Puerto Rico got destroyed by the hurricane that was there. And we actually didn't have fluid, which was kind of weird. It was the first time. Sometimes we run out of drugs here or there, but not having any fluid was a whole new shortage type situation. So we're like, well, how do we deliver reconstituted antibiotics? If you have a powder or something, how do you get that into a person if you don't have fluids to put it in? So we had to get really creative and like, well, sometimes we might have a lot of saline, but not dextrose. So how do we move stuff around? So we can get creative. And again, a lot of this stuff is compatible in both. So if you have any concerns about that in your patients, just ask. But otherwise, this is just kind of for your information. Lactated ringers is something that's really only used in OB population. I don't really see it done elsewhere. And then these are all your crystalloid solutions. And then colloid solutions, think about them as larger molecules. You have albumin, which is a blood product, hetastarch and dextrin, and then blood and plasma are all colloidal products. So they're going to have a bit different of a role. Albumin is something that we can, like if you have a person who has sudden blood loss, I think about like procedural areas as being really common, where somebody's in the OR, for some reason they get, the lead comes out during a electrophysiology procedure or something like that, and they start bleeding out, and you can give them a lot of albumin. It gets volume in really quickly before if your patient's it usually takes some time to get blood from a blood bank, but you might have albumin right in the OR there, and you can push that in. So those are really the purposes of colloids. It's just a little bit different. Packs volume in, keeps fluids from leaking out, third spacing type things for people who might be malnourished and have low albumin to begin with as well. We can supplement it that way, so there's other options there. Colloids, because they're human blood products, well, at least albumin is. Head of starch and dextran, I rarely ever see this used. Technically, it's a colloidal product, but you can probably just ignore it. But albumin is expensive. Blood products are expensive, so it's a lot cheaper to run a bag of salt water in somebody for fluid replacement. So we don't use that for standard fluid, but in some patients, they might require colloidal fluids. And in case you're curious, this is what's in all the fluids and the different milliequivalents per liter you'll see in a different bag of fluid. So like if you're curious about lactated ringers and what is actually in it, there is lactated ringers. LR, there it is. So you're like, oh, there's all this weird stuff in it. Yep, there is. I don't know what else to say. I don't really know the advantage of it or why they use it. It's probably one of those historical things, but I'm sure normal saline probably works just fine. All right. So we're going to talk about different electrolyte abnormalities now, and starting with sodium disorders. So sodium is mostly related to somebody's hydration status. It's rare to get sodium disorders for other reasons. There are some drugs that can cause it too, but for the most part, it's hydration status. So signs and symptoms due to cell volume changes, serum sodium levels can give you an insight into extracellular fluid issues, and you have a rapid shift of sodium and water, especially in places like the CNS, can cause serious damage. You can get demyelination and other neurological implications that can be fatal if not treated correctly. So when we replace sodium, whether it's low and we're trying to replace it that way, or whether it's high and we're trying to replace fluid, it's really important to do it slowly. If you do it fast, that's where you get big issues with sodium. So hyponatremia is the more significant one. Hypernatremia is really, really rare. I don't think I've ever really seen an emergent case of hypernatremia. Hyponatremia I've seen a couple times. This is sodium, usually less than 135. On the exam, I don't care if you know your lab cutoffs. You probably should for real life, but every lab has slightly different cutoffs. So some institution you go to, their hyponatremic cutoff might be 130. It just depends on how they calibrate their equipment sometimes, but 135 is probably the standard. So anyway, most people who are at risk for hyponatremia are going to be elderly or neonates, and usually we only get clinically concerned on this when it's really, really low, a sudden acute change, or how they're presenting. So if somebody comes in and their sodium's like 129 and they look fine otherwise, it's probably not a big deal. Some people have kind of transiently low sodiums for whatever reason. It might be because they have some renal issues. They might be on diuretics. They just can't keep the sodium up. They might be on some antidepressants, waste sodium transiently as well. So there's some things like that that just wouldn't have any clinical impact on the patient, but they just kind of always ride low on their sodium. So what are we looking for with clinical symptoms? Mild symptoms would be lethargy, muscle cramps, anorexia, nausea, headache, really unspecified, right? That could be any number of things. Severe symptoms are where you get really concerned. So if somebody has a low sodium and they have altered mental status, specifically almost looking at like psychosis sometimes, that is an obvious flag of, okay, does this person have a mental health history first and foremost? If they don't, it's probably the sodium. I've seen a couple cases of this, hyponatremia-induced, or psychosis from hyponatremia, I should say, or psychotic-like symptoms in people who didn't have any history of schizophrenia or anything like that. And I'll talk about those reasons here in a second on this slide. So causes, sometimes you can get, if you give somebody a lot of D5, so another reason why we don't use D5 as a maintenance fluid is it dilutes out sodium over time. And if you're giving normal saline as an alternative, then that's going to keep your sodium kind of at its status quo. So sodium, normal saline is 154 milliequivalents per liter. So that's about what you'd be hard to get higher than you want to. So it would replace it slowly over time. But if you're just giving D5 to somebody as a fluid over time, that's going to dilute out their sodium. Hyperglycemia can sometimes cause hyponatremia, so you get an increase in serum osmolality, causing water to be pulled from extracellular space. So you're diluting out the sodium. That's why volume, fluid status, and hydration status is really key to this. I don't care any of these calculations, but just know that you can calculate a corrected sodium in a patient. So if a patient comes in really hyperglycemic and their sodium looks kind of low, you could always do a calculated check there that's going to be their observed blood glucose, and it's got some variables there that are some constants there that it puts in to see what your expected decrease would be if you're going to correct it, and then like what the decrease by versus the increase in blood sugar. So anyway, that's there. Again, I don't care you know that calculation, but just FYI for your hyperglycemic patients and their sodium issues. More commonly, probably going to be hypovolemic issues is what you're going to see. Dehydration, diarrhea, diuretics. Now, this is interesting because you might think if you get dehydrated, you would actually concentrate sodium, which is true, but it depends on how you're getting dehydrated. So if you're just like stuck in the desert for a week and you didn't drink a lot of water, yeah. But if you're on furosemide or a loop diuretic or something like that, and it's wasting, or even worse, a thiazide diuretic, maybe you overdid it on your metolazone dose and you ended up peeing out a whole bunch of sodium, that's what this is going to happen, or what you're going to see here. And in fact, the couple times I've seen severe hyponatremia is from patients who were recently started on chlorthalidone. I've seen 2 cases where the patient started chlorthalidone like a couple weeks earlier, and they came into our ER almost psychotic because their sodium was so low. So it's another reason why chlorthalidone scares me a little bit. I'm sure those are like 2 out of 20,000, but still, it's kind of scary to think about it. Heart failure, nephrosis, hepatic cirrhosis. These patients are probably going to be volume up, which is going to dilute their sodium out. Renal failure, SIADH, polydipsia, usually probably going to be volume neutral more or less. They're still going to see low sodium levels with them. Consider rate of decline and severity of current disease state. So that's always too. Are they having a heart failure exacerbation? How fast? Do you have another lab value to look at? How fast did they drop? Those are all the things we want to look at. And what's their baseline? So again, that person who's kind of low, maybe their baseline's a little low to begin with, so a little bit of a drop's not as big of a deal. If something's clinically serious, like if you're starting to see any type of neurologic changes in a hyponatremic patient, that's where you want to be really quick with your actions. Now, again, we don't want to blast them with sodium and reverse it really quickly, but you do want to act fairly aggressively because that's where you can end up with brain damage if you don't do something. So non-critical sodium replacement, I would say, would be somebody who's like, their sodium's low, it's low to the point where you're uncomfortable with it, but they aren't really symptomatic. Or maybe they're having some of the mild symptoms, some lethargy, some muscle cramps, things like that. In that case, fluid restriction or oral sodium tablets, just salt tablets, is plenty probably for those people. You could always replace fluids with normal saline if they happen to be hypovolemic. The normal saline, again, is enough sodium that it should over time bring them back up, although it do it pretty slowly, and any offending agents. So we haven't talked about psych meds, but there's a number of antipsychotics and a couple of, mostly antidepressants actually, and a couple of medications used for epilepsy and other psychiatric conditions that are notorious for kind of wasting sodium, either in small amounts or large amounts sometimes. If they're critically ill, so if, again, I think of like the altered mental status, neurologic changes, psychotic changes being the kind of cutoff there between non-critical and critical, that's where you get really worried. Or if they just come in and their sodium's super low, like it's 110 or something ridiculous, maybe they aren't symptomatic, which would be weird, but it's possible, but you still want to replace that pretty aggressively because it's probably only a matter of time before they start to show symptoms if they're that low. So usually in these patients who are critical, we use hypertonic saline, which is 3% saline. And you do it at a rate that's somewhat aggressive yet gentle, I want to say. So you want to increase the serum sodium of 12 milliequivalents per liter in 24 hours. So the goal here is just, I guess what we do in this situation is just monitor really frequently. So like every hour or every 2 hours, checking sodiums. You can always pull back the sodium. Maybe you overdo it a little bit at first. It's probably not a big deal, but it's the whole day is what you're looking at. So pull back the rate if you need to, because overly fast correction will cause osmotic demyelination syndrome, and that'll cause encephalopathy and neurologic damage that can be permanent and fatal potentially. So you really want to be careful. It's the reason why hypertonic saline is sort of a high-risk medication. It's something we don't just dispense willy-nilly. When we dispense it, we put these big stickers all over it that say concentrated electrolyte. It's something we don't ever stock out on the floors just because we're terrified that somebody might grab it and think it's like a bag of regular saline and accidentally infuse it, and then we're in really bad shape. So something, yeah, it's sequestered in the pharmacy. It's got a specific spot, and you have to request it specifically. So anyway, it's something that can be used. Certainly, it's got a good medical indication for it, but it's something we're really careful with. So that's one thing I want to know. It's very high risk. You can go to this global RPH deficit calculator here. I just want to show you an example. I have a funny story. The first time I ever saw a hyponatremic patient, I freaked out because I had no idea what to do. I mean, I knew what to do. It's like replace the sodium, right? But how do you do that and how fast you go was what the... Okay, what's going on? Yeah, let's try Google. Anyway, my story. So the ED doc I was working with wanted me to figure out how fast I should run hypertonic saline in this acutely ill patient. And I found these really complicated equations on UpToDate, and I started doing all this math, and it was super weird. And finally, after like probably wasting way more time on this than I should have, and the doctor kind of, well, he was a really nice guy, but I think I was slow, and I should have had a better answer for him. But anyway, it ended up just taking way too much time. And finally, I had an answer. We started it. And then the next day, I talked to my coworker who had been practicing emergency medicine a few years longer than me. And she's like, "Oh, just use the global RPH calculator. It takes like 2 minutes." And sure enough, I did it, and I got the exact same. Well, I got I calculated like 51 milliequivalents per hour or something like that. And this one did like 50. So it was basically the long and short of it is I wasted a whole bunch of time. Okay. So you have nice stuff on the internet that helps you out. And again, Global RPH, despite the fact that it tries to advertise all these weird things, is actually a legitimate site. I feel kind of bad for them because they're probably just trying to make money. All right, so let's say they come in at 110. 100 would be super low. Let's say they come in at 110. And remember, we want to go up 12. I don't know, let's just leave it like this. Maximum rate of increase. I'm going to leave all these here and submit it and see what it says. So there's all our information we entered, and then we scroll down, and it's going to say, should say your rate here somewhere. So it gives you the rate if you want normal saline, and then it gives the rate if you want hypertonic here. So where is the rate? Oh, 40.9 mils per hour. So this is the number you really want because your nurse is going to be like, how fast should I run this? And if you're ordering it, you're the one who has to put in that rate. And the rates aren't defaulted because it's a high-risk medication and it's not kind of a one-size-fits-all. So you can, if you want, and if you're bored, you could play around with this. But basically, you're going to get 25 to 50 milliliters per hour of hypertonic for most people. So if you're kind of in that ballpark when you start somebody, even if you don't have time really to think about it too much, if you're like, this person's acutely ill, what should I start them at? If they have altered mental status and they're hyponatremic, 50 is probably a good place to start. Check a sodium again in an hour, and you can always drop it a little bit from there. So, or you could go to this website or ask, a clinical pharmacist, but it's probably going to be somewhere in that range. So I don't want to make it sound like it's pretty simple to do, but it's not as complicated as you think. So if you end up looking up these, I don't know what other classes teach or what references you have, but if you end up seeing these really complicated sodium replacement calculations, they are really complicated. This is the way to do it. It's much easier just to use a reference. So that's my experience. Hopefully you don't really ever have to deal with it, but it is there if you need it. Okay. SIADH is syndrome of inappropriate antidiuretic hormone secretion. Basically, it means you have too much antidiuretic hormone going on. It's drug-induced, generally. So a couple of different medications. The most common ones that people are going to take are going to be SSRIs, which are selective serotonin reuptake inhibitors, are the most common class of antidepressant. There's probably 100 million people that take them worldwide, maybe more. I don't know. It's a super common class of medication. So it's not really common to see this, and if it is, it's probably on the low end of the spectrum, meaning they might get a drop in sodium slowly, but not going to be significant enough to warrant any type of clinical intervention. However, you can treat it if it does happen, and you're going to see hyponatremia if they do get SIADH. So fluid restrict, increase your sodium intake. Again, you treat it just like you would a bulimic case or any of the other cases we talked about. And so I just wanted to point it out differently because I don't know if you guys have talked about this before, but it is a common cause of drug-induced hyponatremia, and that's the way it works. So again, pretty much the exact same thing. People, if their volume up, you can use loop diuretics to get off the free water. You can give either oral sodium replacement or even go all the way up to hypertonic if it's severe enough. There are some drugs called vasopressin receptor antagonists, or VRAs, which I just want you to be able to recognize these and know what they are. They're kind of odd drugs, and they're really expensive, and I tend to frown upon using them just because I don't really understand what they offer over fluid restriction and sodium replacement. But if that's not working, that's kind of where you have to go. So for people who have really severe SIADH, these drugs are available. They're called the Vaptans, and there's 2 on the market, Conivaptan and Tolvaptan. They promote free water loss via without sodium loss via decreasing collecting permeability to free water. They're kind of like a diuretic of sorts, like a sodium retaining diuretic is an easy way to think about them, I think. You give them an IV loading dose. They're only IV. You don't give these medications oral. And a 24-hour infusion, have a duration of about 4 days maximum before they have start diminishing returns on their benefit. You can overly correct the sodium, especially if you're giving hypertonic saline at the same time, which sometimes is the case. If you have really low sodium in a really severely ill patient, you might run both concurrently, and then you really have to monitor. Again, a lot of this is easy to do if you're monitoring correctly, so making sure the labs are ordered and things like that are going. Place in therapy, acute, expensive, and again, there's not a lot of good evidence that I've seen over just fluid replacement and hypertonic saline in an emergent situation. So the use of this is limited just because of its cost and the questions around it. But again, if you're doing those things and you aren't getting anywhere with it, or you're not getting to the goal you want, sodium's still low, you could give one of these medications to help bring it up.
Is this specific to the SIADH, or is it?
Usually it's SIADH related, but technically it could be used in any hyponatremic situation. Yeah. All right, switching gears to hypernatremia. So too much sodium, usually going to be caused by dehydration, plus or minus increased sodium intake, mineralocorticoid use, and diabetes insipidus. And again, dehydration being not associated with a diuretic that's going to waste the sodium. So that's the big difference here. Much less common. Again, I don't think I've ever really seen a significant case of hypernatremia that I can remember. High serum sodium is usually something over 160, and it's usually indicative of cerebral cellular dehydration. So it's certainly serious, but again, it's really, really rare to get your sodium that high. So treatment, if the person's volume down, you want to rehydrate to restore intravascular volume. That should dilute out the sodium and really take care of the problem. That should handle most cases of this. If the patient is fluid overloaded for some reason, so let's say maybe they have diabetes insipidus, which is more or less a kidney-related disorder where they're going to be not excreting sodium correctly, or they had a course of mineralocorticoid use, like fludrocortisone, they're on it for some reason, or maybe they overdid their fludrocortisone. That might be a reason why they have it and be both hypernatremic and volume up. In that case, use a loop diuretic. That'll get rid of the fluid. It'll excrete some of the sodium as well. Thiazide diuretic on board as well for synergy, and sodium wasting would help in that situation too. If you do have diabetes insipidus, free water decreases, and consider desmopressin. So desmopressin is a medication that's synthetic antidiuretic hormone. That's all it really is. And this is its only real role is for diabetes insipidus, people who have hypernatremia, and it's to help them balance out the fluids and electrolytes in those situations. You can give it orally. It also comes as a nasal spray. So that's really all I want you to know about this. Not anything much more than the volume restoration. However, there are these kind of odd scenarios where you might have to do something else with a loop or the desmopressin in some odd cases. But again, it's kind of rare. All right. Sodium abnormalities, I'd say just as a whole, are rare. I mean, I said hypernatremia is quite rare. Hyponatremia is, to the clinical extent, is quite rare too. I mean, I've seen like 2 memorable cases in my 5 years in the ED, so it's not so. Whereas like potassium, you see hyperkalemic patients like every single day. So potassium levels are intracellular insight markers here, whereas sodium would be the extracellular. So they're responsible for potassium is responsible for protein and glycogen synthesis and resting membrane potential, and it can significantly affect cardiac neuromuscular activity, specifically with respect to conduction and arrhythmic potential. So potassium changes are the ones we really care about, and that's something you get really scared of So we want to keep that within range, because if not, they're at a cardiac arrhythmia or an arrest, and that's really hard to come back from usually. So where we can correct sodium to a certain extent, and you can correct the neurologic changes, it's a little bit easier to do that. If somebody goes into cardiac arrest, that's difficult to get somebody back from that. Hypokalemia is the better one of the two if you're going to pick one. Usually asymptomatic until potassium gets really low, and at that point you might see some muscle weakness, maybe like severe muscle breakdown like rhabdo if somebody has really low potassium, but mostly asymptomatic. And then if the potassium does get quite low, you will see the cardiac effects start to come into play. So it's kind of easy to remember, because if you're hyper or hypokalemic, eventually you will get cardiac arrhythmias. Sometimes people will get reduced insulin secretion, which causes glucose intolerance as well. That prevents the cardiac myocytes from being able to metabolize energy source, and that can sort of compound the issue there. Generally not serious, pretty easy to correct. It's super easy to replace potassium. Oral potassium is like 100% bioavailable. We give potassium chloride tablets. If somebody can't tolerate oral, or if they're really severe, you can give them IV potassium chloride, and that will bring their potassium quite quickly. Same thing with, just like I was saying with sodium, all it requires is monitoring. A lot of protocols are nursing driven, so you might say this patient's K is low, I'm going to order a potassium replacement protocol. Your nurse will see that order come through. They'll put in the potassium orders. Pharmacist looks at the potassium order, says, yep, that looks good based on the protocol inputs and the lab value, and I'm going to verify it, and then the nurse will hang it, and they run the labs and everything like that. And you just get to watch from the sidelines and check the labs and make sure everything's going okay. So it's a nice way. A lot of hospitals run that way. So from a provider standpoint, it's pretty easy to replace potassium. And generally, again, potassium products are easy. They're bioavailable, and it's a simple, straightforward way to replace people. One little thing is that if somebody has low magnesium as well, magnesium is a cofactor for potassium uptake. So if you don't have adequate levels of magnesium, you can replace a lot of potassium, but you might just not see it present. And that's intracellularly, you'll end up with an issue there. So it's really important to replace both of them. And just make sure you're checking both. And that's a similar replacement protocol along with the potassium. So a lot of times people will order both. Certainly if you have somebody who's really hypokalemic and you want to get it in quickly and you don't really have time to wait for the mag, or the mag level's pending or something, you can always give them potassium. It's not like it's going to hurt them if their mag's low, but ultimately you want to replace the magnesium as well. Okay, so a couple options. Oral, again, I said it's very bioavailable. The only problem with the oral tablets, I would say, is they're huge. If you've ever seen a potassium pill, they're like the definition of a horse pill. So I've got a picture of them here, and people don't like that. Even like healthy people don't like taking giant pills. So it does come in a couple other forms. There's powder packets, and you could like mix those in with applesauce or something like that if somebody doesn't like the taste of them. There's liquids too. You can actually take these tablets. They're kind of cool. They're like, think about a bunch of little styrofoam balls stuck together in a tablet. That's what these are. So there's this matrix that keeps all the potassium together. And you can actually put it in like a little bit of liquid, and it'll dissolve to the point where it's sort of a slurry. You just can't crush it. You don't want to physically crush the matrix that it's in, but it'll dissolve in water, and people can take it that way if they want to swallow it. So again, there's a number of ways to do this. I just want to make sure if you have patients in the future like, I can't take those huge tablets, I get it, but there's other options. IV, usually reserved for severe or potassium less than 2.5. And IV potassium chloride is another medication I consider relatively high risk. If you give somebody IV potassium and they have normal potassium, you could put them into hyperkalemia and then cause an arrhythmia that way. In case you didn't know, potassium chloride in really high concentrations is part of the lethal injection cocktail they give people. So yes, if you give somebody enough potassium chloride, they will die. It's something we watch really carefully. And that's why people who are hyperkalemic have such issues with cardiac arrhythmias and arrests and things like that. So dietary changes, not super effective. So like if your potassium's low, you can't just eat a bunch of bananas. For some reason, the dietary sources just don't get bioavailable to the point where you can ingest too much of them, which is probably really good, because if somebody ate a ton of bananas, you don't want them to get arrhythmic because their potassium's really high. So, and there's some over-the-counter potassium supplements too, that some seem to work. I actually had a patient come in, like a 40-year-old woman, no medical history really to speak of, healthy otherwise, in a cardiac arrest, and we actually got her back, which was great. but we found out later it was because she was taking a bunch of over-the-counter potassium supplements because she thought it would help with some muscle cramps she was having, and that turned out to be almost fatal for her. So potassium, be careful with it. It's not something you want to mess around with. Normal requirements for most people's daily intake is about 40 to 80 milliequivalents per day. So somebody's low or they're on, there's going to be a lot more diuretics in the next lecture. I don't know, some of you guys probably watched it or maybe not, but that's sort of the baseline replacement. And if somebody is on something that's wasting potassium from their bodies, like a loop diuretic or notorious for doing this, that's sort of the goal. So you'll see a lot of people who take loop diuretics regularly be on like a 40 milliequivalent per day regimen of potassium. Again, I talked about protocols, and then following up of the labs is super important. Again, we don't want to forget about what we're doing. It sounds obvious, but that's really important to make sure somebody's checking those labs. So it's always a good idea, even though the nurses and pharmacists should be checking. Of course, you guys should be looking at it too and making sure everything looks good, or is trending in the right direction at least. All right, Hyperk, serum potassium greater than 5 usually. Dangerous. The most common patient presentation are renal failure patients, so either acute kidney injury, but more commonly people who just decide they don't want to go to dialysis for whatever reason or dialysis non-compliant. Those are the patients who come in and their Ks are way out of whack. They're in an arrest or something like that. It's really bad. EKG changes are usually observable in people with hyperkalemia. Wide QRS complex, peak T waves, smaller absent P waves are kind of the things you would look for if somebody is not presenting with any direct symptoms, but they have a high K. You could start to see some of that on the EKG, and that's a sign that they're moving really quickly toward an arrhythmia. I've seen people come in where they've had peak T waves, and all of a sudden we start medically managing them aggressively and can't do it fast enough to get the potassium to shift back into the cells. They'll go into an arrest. Treatment based primarily around driving potassium into the cells. I'll talk about those treatments here in a second. Basically, we look at the EKG first. If there's acute changes, you want to start by stabilizing the cardiac membranes first. And if there aren't any acute changes, we just want to get that potassium down and do it safely. So, step one. Step one's probably the most confusing for people, so I want to say it a couple times. First of all, you have to look at your EKG. And decide if you want to give calcium chloride or some sort of calcium product. IV calcium stabilizes the cardiac membrane, and that's the first step if somebody is hyperkalemic and has EKG changes. If somebody is just hyperkalemic, you don't have to worry about the calcium. Calcium doesn't do anything to decrease potassium. It just helps stabilize the cardiac membrane by helping allow the cardiac myocytes to work via calcium channels like they normally would. That's basically the mechanism there. So if step 2, you really just want to drive drive potassium back into the cells. And to do that, there's a number of different options, and it really depends on how severe the person is. If somebody has severe hyperkalemia, like if they've got a K of 7 or something like that, the best and most effective way to do that is to give them a bump of insulin. So IV insulin, we haven't talked about insulin yet. Obviously, most people know what insulin is, but insulin has a side effect that can be used to its advantage here, where it pushes potassium back into the cells. It does this by basically stimulating the sodium and potassium ATPase and causes potassium to shift intracellularly. So we give 10 units of regular insulin IV push. Regular insulin, as opposed to a bunch of other insulins on the market, it's the only one you can actually give IV, so that's the product we use. Now, we might give dextrose first, and it depends if the patient's blood glucose is high or not. So if all this kind of revolves around insulin. And if they come in and their blood sugar is normal, or if it's low, you definitely want to give them a bunch of dextrose to make sure you don't bottom out their blood pressure, because that's a whole nother set of issues you have to deal with that we haven't talked about yet. Finally, there's a bunch of other stuff you can do. You can give sodium bicarbonate, which we haven't really talked about, but basically has kind of a similar mechanism to insulin, just not quite as effective. Albuterol nebulizers continuously can help get potassium back into the cells. Loop diuretics you might be thinking of, those waste potassium, yes, but they're slow. It takes like an hour, 30 minutes at max to start seeing diuretic, or at minimum to start seeing diuresis with a loop diuretic, and yes, they will waste potassium. They're a really great option if your patient's transiently or just slightly hyperkalemic and you want to get some of it off, but you don't have any real reason to be in a hurry. It'll waste the potassium over time, so it's a great option for that. But otherwise, in severe cases, you want to go to the IV options. Finally, There's sodium polystyrene, which is an oral GI agent that focuses on exchanging sodium for potassium in the GI tract. Basically, it pulls potassium out, so you excrete it in the feces, and that takes quite a bit of time too. It's about 24 hours to see the effects of K-oxalate. So if you're doing all this sequentially, K-oxalate's like the last thing you really care about. But if you had somebody who, again, really had mildly elevated hyperkalemia and you just wanted to bring it down slowly over the next day, it's not a bad option either. So there's a couple different ways you can do it. It really, stratification is up here. This would be like everything, the kitchen sink, if they have EKG changes and they have really severe hyperkalemia. And then it just kind of, you knock things off based on that. So again, Lasix, K-oxalate, great if the person has no symptoms and is mildly hyperkalemic. Heavy hyperkalemia, you're probably going to give them insulin. Even if they don't have symptoms or EKG changes, you're still going to give them insulin in most cases. All right, calcium, since we're kind of on the topic of electrolytes, let's talk about calcium for a second. Calcium, there's a couple options to replace calcium. So you've got chloride versus gluconate. And I just want to talk about this very briefly. Calcium chloride is more bioavailable. It's got about 3 times the elemental calcium per gram, and it's basically ionized calcium that gets instantly bioavailable. The problem is if you infuse it in a peripheral IV setting, it's hard on the vasculature and you can infiltrate or blow your IV or cause a lot of pain. Gluconate is less elemental calcium, it's slower bioavailability, so its onset takes a lot longer for the ionized calcium to decomplex from the gluconate molecule. And it's easier on the blood vessel though. So if you have somebody emergent, so if they're like in an arrest setting and they're hyperkalemic, you're just going to use chloride because you don't really care. If it's urgent or less severe and you want to, maybe you're just starting to see those peak T waves and not really anything else, patient's looking okay otherwise, gluconate might be fine in those cases. So you will see that difference that people are like, well, I want chloride, I want gluconate. Well, that's the reason why they're the difference. Usually we don't really care about the salt formulation of what we're giving a whole lot. This is one of the exceptions to that. All right, magnesium. So kind of like the third major one that people replace, magnesium, molecular stabilizer. It's involved with RNA, DNA, and ribosomes. It's a natural calcium channel blocker. It's a natural antihypertensive, vasodilation, neurosynaptic transmission, has effects on release of acetylcholine within the central nervous system. It's really easy to get plenty of mag in your diet. So we see low magnesium in people who are malnourished, alcoholic patients. It's really common to see that in. Renal homeostasis is really nice in the sense that you reabsorb most of your mag. You don't excrete out a lot in the urine, so you don't have to replace a ton a day. But again, if you're messing with somebody's diuresis status, so if you're giving them loop diuretics, they're going to waste some magnesium probably. So that's where you need replacement protocols and monitoring and lab values and things like that. Hypomagnesium usually occurs in hospitalized patient, critically ill. Again, I talked about alcoholic. People would think about GI or renal-related disorders. Drugs might cause it too. Symptoms are usually relatively mild. Severely, you could have neurologic effects. I've seen really low mag with virtually no identifiable symptoms, so it's not something I get super worked up about, and you can replace it pretty easily too. So again, it's not as significant of a concern as potassium, let's put it that way. Goals, we want to resolve any signs and symptoms, get your magnesium above 1.8, correct potassium as well if that's low. Remember, we have to do both. And you've got oral options. Oral magnesium is tricky because it's not that it's not bioavailable, it's that your body can only absorb so much, and it causes quite a bit of diarrhea too. So if you ever heard of some of the magnesium related like magnesium citrate, I don't know if anybody's had to see that or give that to a patient or anything like that. It's kind of like on the drugstore counter in glass bottles. That's a laxative basically is what it's used for, but it also could be a magnesium supplement, and all magnesium has a laxative effect. So sometimes they'll just say, well, give them magnesium until they start having loose stools and then stop, because at that point we can't. It's like, well, you're giving your patient diarrhea. So on the outside, on the outpatient world, that's all you can really do to replace it. And you can give some slow release products, like there's this slow magnesium product that is an over-the-counter supplement you can buy that should delay it enough where you don't really get diarrhea. And that's really great for people who maybe are just slightly low on their magnesium and could use a little bit of a bump. But generally speaking, magnesium oxide, 1 to 2 to even 3 times a day is what you see orally replaced for people. Now the IV is nice because it doesn't cause any diarrhea really. You can give more of it, and it just doesn't have any of the absorption issues associated with PO. So if you really need to replace magnesium, and of course you're in the inpatient setting, IV is going to be preferred for a lot of reasons. So it's not like potassium where if we can give oral, we prefer it just because it's really well absorbed, doesn't really have a lot of side effects. It's less likely to cause a medical error or risk infection or anything like that by accessing an IV site, but in magnesium it's kind of the opposite, where we prefer IV in most cases if we can. All right, hypermag, very rare. I don't know if I've ever seen this before. Basically, if somebody was, think of a scenario where somebody was taking magnesium products to replace, and they also got acute kidney injury, and their kidney stopped excreting any mag whatsoever, so they're just accumulating it. That's probably the only scenario I can imagine. You can end up with pretty severe CV and neuromuscular complications, but again, really, really rare. So I don't want you to know too much about this, other than just you would use some fluids, loop diuretics, try to dilute out, excrete out some of the magnesium. I do put this magnesium citrate product on here. Again, this is OTC. If somebody was like, I don't know, use maybe sometimes people with eating disorders abuse laxatives. This is a common over-the-counter laxative, so it's certainly possible somebody might be drinking a lot of this. And they might end up absorbing enough to get hypermag. But even in that case, I think it'd be pretty rare to see symptoms, but it's possible. All right, that's all I've got for those. Again, those are the big ones I wanted you to know. There's a lot of other little things out there certainly we can talk about, but it's not really worth the time. So that's it. Any questions on those topics?
I have one other question.
Yeah.
Why would you give dextrose with medications?
With medication.
Or like when you were saying at
Which
the
slide?
very beginning, is they're using like normal saline?
Oh, because some medications, like if you have medication that comes from the manufacturer in a powdered form, they might say specifically this is only stable in water or dextrose. We can't tell you if it's stable in normal saline because for some reason we decided not to test it. So we can only put it. Some things aren't. Sometimes they will test it in saline and they'll get a particulate matter and they like clumps together due to some reaction, and so then they can't put it in there. So there are some products that are restricted to one reconstitutable fluid or not. Yeah. Most of them you can put in both, but yeah. Yes.
You can get either a toxicity or just use it as a normal replacement, like the CalMag D things.
Yeah. We're gonna talk a lot about calcium and vitamin D during the osteoporosis lecture. That's going to be the first one slated for the spring. So I'll hopefully answer most of those questions then. But no, it's really hard to get toxicity from that.
Is it a valuable supplement?
Long and short of it, there's some evidence that says calcium with vitamin D prevents osteopenia and porosis. My general opinion on it is it may not, but it's virtually harmless. So for like somebody who's at risk for osteopenia, it's probably worthwhile because it's relatively cheap and easy to take. Doesn't really have any side effects with it. All right, there is a renal case here. I'm not going to go through it just because I'm guessing most of you haven't watched the video. Maybe you have, and if so, great. But I will post a little summary on this, on what the answer is and what I was thinking. It's kind of just like the case for this. And the vitamin D part you could ignore because we didn't cover that this time. So for renal is going to be the renal lecture, and the series of renal topics that are all kind of in that big lecture that's posted right now is going to be the majority of what's on the exam. Obviously, there'll be stuff from this lecture too. A couple questions from the incontinence lecture, but as you guys might know, that was really short, so only a few meds to know there. So knowing all the stages of renal disease, so from chronic complications to acute kidney injury, and looking at the ways we can remove fluid when the kidneys aren't working, and kind of basically all the drugs we'd used up until the point of putting a patient on dialysis is where I want you to look at with that. So I think it's pretty spelled out in the lecture, but first get a couple weeks until the exam, so get some time to chew on it and ask me any questions you might have. I'll post the forum at some point here, so feel free to use that. I know I don't think anyone used it on the last exam, but definitely ask me questions through it. I do try and check it. And if I forget to check your question, I try and check like Sunday during the day before the week of the exam. That's like the last time I usually check in. But if I don't answer your question, definitely email me, because I don't get notified if you post there. I have to remember to check it, which I'm bad at. So definitely let me know. All right. Any other exam related stuff or questions about the content?